Hi, this is Ileana Piña. I'm Professor of Medicine, Epidemiology, and Biostats at Case Western Reserve University. And I am here with one of my colleagues, Dr. İlke Sipahi, who is part of our heart failure faculty at the Case Western Medical Center, University Hospitals of Cleveland. And he has recently published a paper that has spawned a lot of discussion in medical circles, and it's even caused discussion in the news media concerning angiotensin II receptor blockers and cancer. Let me just preface by saying that angiotensin II receptor blockers are incredibly widely used due to their very good side effect profile in millions of hypertensive patients, alone or in combination with other drugs such as diuretics, hydrochlorothiazide, and in heart failure indicated in the guidelines for patients who are ACE intolerant. We have data both in hypertension and we have certainly data in heart failure to the benefits and endpoints of these drugs. Dr. Sipahi has been kind enough to join us today and participate in my blog and talk to us a little bit about the paper, and so I'm going to be directing some questions to him. The paper has been published in Lancet Oncology just within the last 2 weeks, so I think we're really timely on this. So İlke, thank you very much for joining me. First of all, talk to me a little bit about the biologic plausibility of this link, and how did you come up with it?
It's been long recognized that the renin-angiotensin-aldosterone system can play a role in the development of human malignancies, especially both the angiotensin II 1 receptor and the 2 receptors have been specifically studied.
Both of them in the same degree?
Both of them have been studied, but the data have been very conflicted using basic science information, using animal data so far. Some studies have suggested that they can prevent occurrence of cancers, whereas others have suggested that they increase angiogenesis really aggressively. And
the drugs or the receptor?
The drugs, actually.
Okay.
There's an elegant study by Walther and colleagues published in 2003. The study was done in Germany. It's an alginate model of tumor angiogenesis, and in there, blocking the AT1R receptor with losartan caused a threefold increase in angiogenesis. The reason I wanted to do this meta-analysis was not actually animal data, but I have been following the trials, and I have been noticing that, as you remember, in 2003, the CHARM trial reported a statistically significant increase in fatal cancers.
Okay, I'm going to go into that in a minute. So just to remind you, we did CHARM. We did it here, and we did it at the VA. So let me go back a minute. Looking at the literature, I find a lot of literature on, you're right, on prevention or treatment, and yes, linking angiogenesis to the AT1 receptor, but particularly the data are pretty robust with telmisartan and prostate cancer. And not only prevention, but treatment and augmentation of chemotherapy. And I have found data also on breast cancer and even lung cancer, which you mentioned in the paper. There's a beautiful review by Rosenthal, which appeared in 2009 in the Journal of Human Hypertension, discussing the benefits of A2 receptor blockers and even ACE inhibitors on prevention or treatment of malignancy. So in this paper, you have really given it a turnaround to a causation. So let me take you back to CHARM. So CHARM was how many arms?
2 arms, placebo versus candesartan, but it had 3 different studies, 3 different
actually there were 4 studies. So the total study is the 4th study. Which of those sub-studies or total studies had the cancer incidence that you're talking about?
In the main publication of the CHARM trial, the cancer data...
Of the program or the trials?
Of the program.
Okay.
Cancer information was only presented for the overall program.
Okay.
When you go to the FDA website, you can find additional cancer information.
I'm going to come to the FDA website now.
And it appears that most of the excess cancers were coming from the CHARM added components of the CHARM program.
So in other words, for our viewers, to remind them, this is an addition of an ARB, namely candesartan, to an ACE inhibitor, and everybody in the trial had to be on an ACE inhibitor, and the results were actually positive for reduction of events, and no interaction with beta blockers. So I just want to make everybody sure of that. Do you think it's the ACE inhibitor, or do you think it's the ARB?
Well, the ACE inhibitor was taken by both groups of patients,
right.
and the excess cancer was in the candesartan arm, not the placebo arm.
But I'm saying, do you think it's the combination of the two drugs?
That's a great question, and I have been trying to answer that. In our meta-analysis, we gathered data not from only the TRUMP trial, but from 5 other different trials. And when you look at specifically the trials that did not allow any concomitant ACE inhibition on the ARB arm, there is still a statistically significant excess of cancer development. However, when you look at the trials that mandates background ACE inhibition, the effect size seems to be larger. So the hazard ratio, if there's background ACE inhibition, is around 1.14, 1.15, and it's 1.08 when there's no background.
So we're
ACE
talking
inhibition.
about a difference between an 8% and a 14%, which is still a small one. Now, in your analysis, how did you handle confounders such as smoking? Because, again, I want to go back to the viewers. In your analysis, you have trials of hypertension, where patients may not have as many comorbidities. And then you have really one major trial of heart failure, which is CHARM, which had 7,000 and some patients. But they were older, they were sicker, and they had a lot of comorbidities. How did you handle smoking, for example, as a confounder?
The nice thing about this meta-analysis is it's a meta-analysis of only randomized controlled trials. So there were no imbalances within the trials as far as smoking, age, and other factors are concerned. Because we do not have individual level data, we cannot control for these confounders. But as I said, these are ICTs, so they should be taken care of.
Okay. Let me go to the FDA for a moment. The data that you say you had from the FDA, where did you acquire it from?
FDA.gov.
There's a lot of data in the FDA.gov, but how did you get exactly to what you're talking about?
If you go to FDA.gov and put telmisartan, you get all the documents about telmisartan. You can put telmisartan cancer.
But do you get the raw data, or do you get the transcripts from the
You get the summaries.
Okay. So
very detailed.
But it's different, right? A summary is not the actual data. And again, when we have panels, there are data that are presented in the panel, but that may not be the totality of the data that is at the FDA because it's proprietary of the sponsors. So what you have is the transcripts, which is a lot of information, but you may not actually have the data set.
All the cancer data was presented in there rather extensively of all the patients. Okay. Individual patient level data, patient number 1 that had cancer, obviously they did not disclose it. But there is robust information in there, including all specific solid organ cancers. You can find lung cancer, prostate cancer information in there.
In CHARM.
Breast cancer information for CHARM, for on target, for PROFESS, for transcend.
Right, so CHARM is heart failure, on target is?
Risk reduction.
Right, hypertension, risk reduction. All right, let me take you, we're running out of time here. So now that you have looked at this, do you think that with the millions of patients that are currently on these drugs that have been so successful, that this shouldn't have been noticed clinically? Because when the glitazones started coming out, we in the heart failure world noticed immediately the volume.
I don't think it can be noticed clinically. There are 2 reasons behind that. The first one is cancer is a slowly developing disease. The second thing is this is a modest increase in the risk. If these drugs had been increasing cancer risk by 10-fold, we would recognize it. But because the relative risk increase is around 10%, you need to do a really careful analysis here with adequate follow-up.
So obviously, your meta-analysis is very interesting, and I'm going to try to sum up, and brings out an interesting hypothesis, which is really what it is. And yet, in the literature, the hypothesis is the opposite. So
not fully.
Well, I think there's more about prevention than there is
That
about
is correct.
causation. So what would you say would be the next step? I mean, we have a lot of meta-analysis in the literature that show one thing, and then when you go out and you test it prospectively, it's totally the opposite, or it comes out neutral. So what would be your best advice for the scientific community to do next?
I think right now the responsibility is belonging to the regulatory bodies, the FDA in the United States and EMA in Europe.
Why do you say that?
Because they have individual level data. As independent investigators, we have access to summaries of clinical trials.
So you're putting this all on the FDA?
On the FDA and the EMA, and actually we are really lucky on this matter because EMA, European Medicines Agency, last Friday announced that it's starting a thorough investigation of the ARB cancer leak. They posted it on their website. And
the Lancet is a very European journal, so I can see that. So have you spoken to the FDA about this?
No, I did not.
Okay.
They did not contact me.
How about a randomized clinical trial, which is actually how we usually find the truth in...
That would be great.
It
has to be a big trial.
Right. How would you do it, and what population?
It has to be a big trial. It should be perhaps over 40,000 patients. It needs to have a really long follow-up, preferably at least 5-6 years, because we are looking at
probably
cancer
more than that.
care.
Because if you get heart disease better, what's going to kill patients who are older is usually
right.
disease.
The power calculations need to be done. I don't think it needs to be longer than 6-7 years, because the trials that we use were on average
what
about 4
population?
years.
Because you have a mix-up of populations.
The population that these drugs are indicated. You can enroll heart failure patients.
Different
you can enroll
populations,
hypertension patients.
So you would do it in all the populations.
Hypertension is, I think, the most important area because that's the #1 indication of ARBs.
So would you exclude heart failure patients?
I think you can include them. You could do ACE inhibitor versus ARB.
Oh, that's another trial.
Trial
Give me
within
the
a trial.
design. Give me the design. Give me the design. This
So
is important if we're thinking scientifically.
The most important components in here is 1, size, 2, duration of follow-up, 3, compliance with the medication, 4, the study drug dose.
How about patient population?
Patient population, obviously, it should involve patients that are older because those are the patients who are at higher risk for developing
hypertension?
cancer. Hypertension is the easiest one to enroll to.
And what's your control group?
ACE inhibitor versus angiotensin receptor
But
blocker.
you just told me that in the trial that had the ACE and the ARB, the difference was even
That is correct, but
salient.
ACE inhibitors by themselves have never been linked to cancer. There is a
well, they're actually linked to treatment.
They are linked to treatments. Or you can do 3 arms, like in the ALL-HAT trial. You can compare, for example, a diuretic or a calcium channel blocker to an ARB. And that would have multiple aims, because there are not very many antihypertensive trials with ARBs, comparing an ARB to a diuretic, to a beta blocker. We just have the LIFE trial and the VALUE trial, and as you know, the VALUE trial, myocardial infarctions were more common with ARBs, so maybe you can set the record straight.
But that wasn't the case in CHARM. The myocardial infarction was not high.
Correct, but that was placebo controlled.
So they're all different. They're all very, very different. Who's going to fund this?
I'm not sure if the pharmaceutical industry is going to be...
You really think the pharmaceutical industry would be
FDA
interested?
can mandate that. FDA can mandate a safety trial.
Actually, they can't mandate trials. just for your info, they do not mandate clinical practice. They can't mandate clinical practice. So are you going to be the PI? Huh?
If they make such an offer, I'll think about it.
You'll think about it. Okay, well, I want to thank you for your time today, and I want to thank our audience for joining us. I hope this is of interest. Certainly, with the millions of patients on these drugs, these questions are interesting, and they bring up a lot of concepts. I would want to warn clinicians, it's not the time to remove the A2 receptor blockers from your patient's therapy, given the rate of stroke and hypertension, and given the worsening of heart failure symptoms if the patient is truly ACE intolerant. So the bottom line is we will watch and wait and see what happens. Thank you again for joining me. This is Ileana Piña, and this is my blog.